So we are going to go ahead and get started. Good afternoon, everyone. My name is Elizabeth Aloni, and I'm with Schneps Media. Schneps Media is the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Manhattan, Queens, the Bronx, Brooklyn, Westchester, Long Island, the East End of Long Island, and Philadelphia. Today, we're thrilled to be able to bring you this very important webinar, Ovarian Cancer Prevention, Screening and Treatment, Complete Cancer Care at NewYork-Presbyterian, Queens. And we are very fortunate to be able to have a prestigious doctor from NewYork-Presbyterian, Queens to walk us through all of this valuable information. Welcome, David A. Fishman, MD. Welcome, Dr. Fishman.
Thank you.
I'm going to share a little bit about your spectacular background with everyone. So please join me in learning more about Dr. Fishman. He is the Cancer Center Director and Director of Gynecologic Oncology and Vice Chair of Obstetrics and Gynecology at NewYork-Presbyterian, Queens, and is also Professor of Obstetrics and Gynecology at the Weill Cornell School of Medicine. Dr. Fishman is an internationally recognized gynecologic oncologist, especially noted for his innovative research on the regulation of ovarian metastasis and in developing new methods for the detection of individuals at risk for ovarian cancer and the detection of early-stage ovarian carcinoma. He established the National Ovarian Cancer Early Detection Program in 1999 with a grant from the National Cancer Institute and philanthropic support. Dr. Fishman received his medical degree from Texas Tech School of Medicine and completed his residency and fellowship in obstetrics and gynecology and gynecologic oncology at the Yale University School of Medicine. Dr. Fishman has authored over 300 scientific papers, abstracts, book chapters, and books on gynecologic malignancy. With gynecologic issues. His research has received awards from the National Institutes of Health, National Cancer Institute, Society of Gynecologic Oncologists, Gynecologic Cancer Foundation, American Cancer Society, Society of Gynecologic Investigation, and the Berlitz Foundation. He serves as an editor for 3 journals, an ad hoc reviewer for 43 medical and scientific journals, and is a member of National and International Cancer Institute study sections from the National Cancer Institute and Centers for Disease Control to the Royal College of Obstetricians and Gynecologists. He's received over 43 awards, such as the National Cancer Institute Early Detection Research Network Recognition Award, as well as the Best Doctor in New York and Castle Connolly Best Cancer Doctor in America. He's a member of many medical and honor societies and patient advocacy groups, including the American Gynecologic and Obstetrical Society, AOA, and the Society of Gynecologic Oncologists. Absolutely incredible. It is so wonderful to have you with us, Dr. Fishman. Thank you so much for being here.
Thank you. I appreciate the opportunity to help improve women's health care. So thank you and your company for helping us get the word out.
Absolutely, my absolute pleasure. So I'm going to go ahead and share your presentation here. So bear with me just one moment. And that will get us started with Dr. Fishman.
Again, thank you. So the purpose today is try and convey information that you can take home and share with your friends and family to get better health care. So that's my goal, and hopefully at the end this will be achieved. Next slide. So this is Ovarian Cancer Awareness Month, which is the last day of the month, but obviously this is a continuing problem that we need to address. Ovarian cancer is not the most common cancers, such as breast cancer, where there's over 200,000 women annually diagnosed. In our country, approximately 21,000 women will be diagnosed annually, but almost 14,000 women die annually. So we have a problem with not finding it when we can do something that is curative. Every woman's at risk for the development of ovarian cancer, every woman. And unfortunately, 1 in 78 will develop this. So the survival is based on finding it early, not detecting it when it's late.
Mm.
Next. So as seen here, today, despite all our magical computer sophistication, we still continue to diagnose most women with advanced stage disease. And advanced stage disease does not have great survival. And there's not one ovarian cancer. So there's over 30 types of ovarian cancers when you take in what the histology is and what the grading is, which I can discuss more if people have questions. The bottom line is if we found it early, we have 90% 5-year survival versus a 12 to 15% survival with it's already advanced. Most breast cancers are found early stage. That's why survival is so high. So if we could do a paradigm shift from advanced stage disease diagnosis to early stage, we would significantly increase survival. So we wouldn't have 14,000 women dying annually. So prevention obviously is our ultimate goal, to prevent cancer. But if we could intentionally detect early stage disease, we would save women's lives. So what I'd like to hopefully convey is there are things that you can do today for prevention or decreasing the risk. And then there are things you can do for increasing chance of detecting it early. So next.
That is really a spectacular difference between 90% and 12%. So that really hits home.
It's real.
Yeah.
So gynecologic cancers are a small fraction of the cancers that are seen. So our funding is not nearly as high as breast, lung, colon, prostate. So the government resources are limited, and this is not a high focus area. But ovarian cancer, while not the most common gynecologic malignancy, is by far the most lethal, and that hasn't changed since 1960. So this slide demonstrates that the most common gynecologic cancer is uterine cancer, not cervix, not ovarian. And the reason cervix is so low is because of the Pap test. And that's a test that women can have to pick up pre-cancer. So it's not to detect cancer, it's to detect pre-cancer so that you can intervene so the woman never develops cancer. So here's the greatest challenge. There is no other test as good as the Pap test. It detects pre-cancer so you can intervene to prevent a woman from getting cancer. We do not have any other test for any other cancer that's equivalent to this. So the gold standard is if we could pick up pre-cancer, then we could do something so cancer was never in the equation. Next slide, please.
I have a question. The test, the Pap smear test that checks for that, is that only checking for cervix cancer, or will that be able to detect uterine and ovarian cancer as well?
The Pap test was intended for detecting pre-malignant change on the cervix because the Pap smear is literally a scraping of cells from the cervix. That was the purpose. As we become more sophisticated with higher resolution computer sophistication and molecular analysis, we are able to pick up cancers of the uterus and cancers from the ovary. But unfortunately, that's not going to be pre-cancer. That's going to be usually advanced cancer or cancer. So if you think of a screening test to pick up pre-cancer, that's what the Pap test was for cervix. It never intended was for uterus or ovary. It is now being utilized as a possible, but it's still uncertain. So what is certain today? The Pap test's role is to pick up cervical disease, not uterine disease, not ovarian disease. That's not the purpose. It may be proven to be able to do that in the future, but that's not what it is used for today.
Thank you for that.
And the Pap test will probably be replaced by HPV test, but that's another discussion for another webinar.
Yes, very important thing to discuss for sure.
So if you look at this slide, ovarian cancer is responsible for approximately half of all the deaths.
Wow.
from gynecologic disease. So it is by far the most lethal women's cancer that we see. More women die from this percentage-wise than from any other female cancer, including breast. So the number of women dying and the percentage of women dying is much higher than any other gynecologic cancer. So ovarian is the number one killer of gynecologic disease. Next. So we've already said every woman's at risk. 1 in 75 or 79 will develop ovarian cancer. This slide says there's at least 100 identifiable genes. There's probably close to 600 now.
Wow.
But we can't test for everything. So what we can test for and what we know of are two different things. Commercial tests have to be validated and verified before they can become a clinical test. So there are over 600 genes that we know play a role, and presently there's over 100 that we can test for that are associated with increased risk. And I'll go into what they do, because it's more important to know what they do than what their names are. Factors that increase a woman's risk for ovarian cancer include unintended infertility, meaning women who try to get pregnant who could not, because a woman who's on birth control desiring infertility has actually decreases their risk. So a woman on the pill decreases her risk for developing cancer as compared to a woman who desires fertility and can't achieve it. Menstrual cycle.
Say it again about the pill, because that's a very...
I'll come back to that.
Okay, good. We'll get back to it. Good.
But the birth control pill is a tool that can be used to decrease a woman's risk. But unintended fertility, women who can't get pregnant are at higher risk. Obesity, age over 70. I mean, almost every disease over 70 comes into play. So, if you live long enough, something's going to get you. So I don't think that every woman who's 70 needs to be afraid. But these are just epidemiologic factors that are shown to have association with increased risk.
You say here early menstrual cycles. What is considered early?
Again, the concept of that is antiquated, quite frankly. But 12 years of age, it's really a soft call, quite frankly. But when you go Google and you look for all on the websites, you look in published literature, the number of menstrual cycles is supposed to have an impact on increasing one's risk. But as we become a little bit more sophisticated, we're learning that some of these things, there are other factors involved. It's not just simply when you started your menses.
Thank you.
So what are the symptoms? And this is probably the hardest thing at all. Some women can tell to the hour when they ovulate, but most can't. And we all have kidneys, and most of us don't ever know we have kidneys until we have a horrendous infection or suffer trauma and you have severe pain or you have a kidney stone. So the symptoms are very, very, very subtle, and often by the time you have symptoms, you have large masses that could be as big as a basketball. So symptoms are subtle. If you have, I tell everybody, persistent abdominal pain or pelvic pain that lasts for more than a week, go see your healthcare provider, and in the evaluation, make sure you say, are my ovaries okay? Because I'm male and I'm not complaining, but I don't have a pelvic exam. And having been doing this since 1988, I know it's uncomfortable. The accuracy of a pelvic exam is about 25%. So doctors doing pelvic exams usually don't feel things. And that's where ultrasound comes into play. So if you have discomfort, the ovaries should be evaluated. And the best way, and I'll emphasize this a million times, is a vaginal ultrasound is the best way to visualize the ovaries. And if they're normal size and look okay, at least we know that's not the problem. So discomfort for more than a week, seek medical evaluation. Are your ovaries okay? Yes, great, move on. But I can't tell you how many women are treated for GI problems and they have masses the size of softballs that were missed on exam, but nobody ever thought about doing a CAT scan or an ultrasound. And an ultrasound is a lot less expensive and a lot less claustrophobic, and it can easily be done. So the symptoms are subtle.
It's important to advocate for yourself and make sure that you discuss this with your doctor and request it if it's not something
Correct.
that they suggest.
You need to be an advocate for your healthcare, and that's hopefully what I'll empower people today to demand.
Yeah.
You have to be proactive in your healthcare. Not every doctor's on top of everything, which is okay, but you need to be part of your healthcare solution, not problem. What are the risk factors? So risk factors are, if you're female, you're at risk. Simple as that. That's the main risk factor. Women who've gone through infertility, it's a whole gamut of infertility, and the bottom line is most of us believe you're not at increased risk for having gone through infertility therapy. And as we all know, there are many flavors of infertility therapy, durations and exposures. But the bottom line is, I don't think any woman needs to feel guilty about having gone through, a fertility help to achieve fertility. Pap smears right here. As of today, this is not a tool to detect ovarian cancer. That's not the purpose of the Pap smear. Yes, it may be able to detect it in the future, and it's under investigation as a research tool, but as of today, that is not how ovarian cancer is detected. And we can get into the theories of, does ovarian cancer start in the ovary? Does it start in the fallopian tube and spread to the ovary? Lots of controversies, lots of great science, but there's not much controversy. A Pap smear is not intended, and as of today, this is not a tool to detect ovarian cancer, period. Not negotiable. Certain behaviors, yes. The best behavior to decrease your risk is being on birth control pill. 5 years of lifetime use cuts one's risk in half.
This blew my mind when we talked before and you told me that. I mean, that is just such a no-brainer. And I'm shocked that it was something that at my age, I didn't even know. I mean, that's extraordinary.
Well, it's well known, well documented. It's not my opinion. It's proven worldwide in the medical literature. Even women who are increased risk or have a known mutation, it decreases their risk. So that's something everybody can do.
Hear that. Every woman should hear that and share that information with a friend, because I bet you I'm not the only one who didn't know that. And we need to protect each other. And you all heard me speak about Dr. Fishman's training. This is not woo-woo. This is 100% science, and such important information to protect yourself.
And the doctor should know this, especially the OB/GYN doctors. So I can't fault people outside the specialty, but certainly within the specialty, this is not a secret.
Wow.
Ovarian cancer is confined to the ovary, may not require anything more than surgery, may not require chemotherapy. But again, 75% of the time, it's spread beyond, and women do need chemotherapy, undergo horrifically difficult operations, and it's not a simple procedure. So if one is thought to have or has a mass that might be considered ovarian cancer, my plug is the only medical specialists who are qualified and experts in gynecologic oncology are board certified gynecologic oncologists.
Mm-hmm.
They have the surgical training expertise and the expertise in ovarian cancer treatment that a general gynecologist does not have. It's not an insult. I don't do brain surgery because I wasn't trained as one. So you do the extra 3-4 years of surgical training and medical expertise to be an expert in the treatment and diagnosis of ovarian cancer. So if one has a mass that might be concerning, that my other recommendation is to go be seen by a gynecologic oncologist. So
that was after you have the ultrasound and you find a mass, you would go to an oncologist. Is that when you would seek it?
The issue would be if there's a question that this mass could be a cancer, then I would tell my family, you're going to be seen by a gynecologic oncologist, and let them decide. If they say this is not, I don't think this is a cancer, then a regular, general gynecologist can do the procedure. But if it is a cancer, the only people who are medically board certified specialists are gynecologic oncologists. So make sure you see the appropriate physician for your care. We don't need to do every case, but we do need to do the cases that are cancer. And as of now, only about 50% of women in the United States with ovarian cancer are operated on initially by a gynecologic oncologist.
Wait,
The other
what?
half, yeah, people are operated routinely by the general gynecologists who, oops, it's a cancer. Then the patient has to see the GYN oncologist afterwards, or may have to have another operation.
So would you suggest that if you find a mass, just go to a gynecologic oncologist to be sure?
If your gynecologist thinks there might be a chance it's a malignancy, yes. Again, ask the hard question. Could this be cancer? Yes, then go see a GYN oncologist. Is this controversial? I'm saying probably, but that's okay.
That is okay. So gynecologists are trained to be able to tell the difference between a mass that would be cancerous and wouldn't be.
No, but the radiologists often who do the ultrasounds or MRIs or CAT scans often say this is concerning for malignancy. So if that's something that's stated, then you go see the doctor who's the board certified expert in surgery for malignancy. In this case, it's a gynecologic oncologist.
I don't know. If I have a mass, I'm coming to see a gynecologic oncologist just to be sure.
Well, again,
That's safe. Like you said, if you catch it early, the survival rate is very strong.
exactly. And if the operation is done properly, you have a better chance of survival. Again, that's well documented in literature. Patient survival is improved when gynecologic oncologists operate on cancer patients.
So important to advocate for yourself.
So I'll lose some Christmas cards, but that's okay. I want you guys to be helpful.
We appreciate it. We appreciate it.
Next slide.
Okay. Are you going to talk about know the symptoms? Did you talk about that, or is that the next slide?
No, I did that.
Okay.
Just, the symptoms are very, very, very subtle, but
Here we
pelvic
go.
discomfort. So again, it's well documented that the symptoms can be very subtle. Both the patient and physician can easily miss this. All of us who are gynecologic oncologists routinely see women who are treated by other doctors for abdominal discomfort, pelvic pain, bloating, treated with different treatments. Meanwhile, the cancer is growing because nobody ever did a pelvic exam. Nobody did any imaging to show that there was a softball-sized mass in their ovaries. So very subtle. So as I said earlier, if you have abnormal symptoms, meaning discomfort for more than a week, in the evaluation, make sure your ovaries are evaluated. And my suggestion is ultrasound, just because it's, quite frankly, the least expensive and easiest tool and gives us the best images of the ovaries of any other technology. Transvaginal ultrasound is the best way to evaluate the ovaries, better than MRI, better than CAT scan. So that's my suggestion.
Okay. Look, take these things seriously. That's what's important, is not just thinking, oh, it's no big deal. Maybe I'm getting my period, or maybe I'm, not feeling well, but take these things seriously.
Exactly. Again, if you have a severe headache for a week, you think you're going to seek some treatment. In the process, they're going to make sure you're not having a stroke, right? So they always get a CAT scan. So what have we learned? What's out there in the literature? And this has evolved. So parity, people that have more than one child have a less incidence than people who have unintended infertility. That's known. These are soft calls. Personal and family history is critical. As we learn more and more, and I'll get into cancer genetics in a minute, is if you have a family with multiple cancers, there's a good chance as a woman, you're at increased risk for cancer of the uterus and ovary, just by virtue of what we now know about these gene mutations and what they do, which we didn't know many years ago.
So any cancer, if you have any cancer in your family?
Any cancer in the family, you just have to, when you see your doctor, say, hey, make sure they're aware of your history of cancers in your family. Because as we learn more about inherited cancer syndromes and risk factors, these are critical. So family history and personal history of cancers need to be shared with your doctors, because the question is, am I carrying a mutation that predisposes me, or I could have passed on to my children? So the more you know about your personal and family history, communicate this to your doctors, especially with cancer risk. So they need to ask, or you need to tell them, hey, by the way, my sister had breast cancer, my mother had breast cancer, my aunt had breast, you need to share this information. And even if everybody had colon cancer or prostate cancer, it's still important information because we as healthcare providers don't know unless you tell us.
Mm.
And unfortunately, a lot of people don't take good histories or don't communicate. Oh, by the way, my family has this, I've had that. So share with your healthcare provider, especially with cancer, is there any cancers in the family? It doesn't matter if it doesn't seem relevant.
Right.
Share with that, because our job is to put the pieces together to help you. So you need to help us help you.
Important.
Ashkenazi descent has been shown again that there's an increased incidence of certain mutations in the Ashkenazi Jewish community, which may or may not put them at increased risk, but it's important to understand that if you have a family that has cancers, you may have mutations that you could have inherited and pass on to your children that predispose everybody to cancer. We published the papers that showed that 38% of Jewish women who had no family history, but who had ovarian cancer, were found to have a mutation. And back then, it was only 2 mutations were known. Now there's over 500.
Mm.
So with all due respect, because of this, and the premenopausal Jewish women having breast cancer, we recommended, and globally it's been accepted, that all Jewish women should be offered genetic testing who have breast and ovarian cancer. In Israel, they're recommending every woman. And in the United States, Mary Claire King, who found BRCA1, she's the one who's, her lab discovered it. She advocates all women should be tested for BRCA1 or 2. Now, I'll get into this in detail in a minute, but genes are the architectural drawings for us, but proteins do the work. So just you can have architectural drawings, but somebody has to build the building. So BRCA1 and 2 are genes and they're proteins. So I guess somebody got bored with the names, because usually a gene is named one thing and a protein is named something else. But in this case, we're being efficient. So the BRCA1 and 2 genes can be inherited, and the BRCA1 and 2 proteins are part of the problem. Now, we all have BRCA1 and 2 genes, and we all have BRCA1 and 2 proteins. It's the mutations of these that cause the problem.
Are these similar tests when you do genetic testing, like when a woman's pregnant?
Yes, they're blood tests, correct. So it's very similar in that it's blood tests looking for genes. But I'll go back into this in a minute.
Okay.
Coming forward, because we've seen all these other mutations, we now know that all patients with men get breast cancer too. About 3% of breast cancers are male. All patients with breast cancer, ovarian cancer, fallopian tube cancer, primary peritoneal cancer, pancreatic cancer, prostate cancer, soon to be lung cancer, should all be tested to see if they have gene mutations that cause them to develop this disease, and also could they pass this on to their children. So we'll get more into this. Next slide. So we know from observational studies that one's risk is increased based on personal history, say a woman with breast cancer, 2 to 4-fold increase. A woman with a family history of ovarian cancer, a first-degree relative can increase the risk almost 4-fold. A second-degree relative, almost 3-fold. So knowing your personal and family history and sharing this with your doctor is critical, because it can affect, are you at risk and should we do something else? Obesity, unfortunately, obesity stimulates breast cancer, endometrial cancer, may stimulate ovarian cancer. So there's lots of things that are negative impact from being obese. So obviously, cancer is part of it. So is heart attack. Endometriosis, which you can't control, has an increased incidence of cancer with it. But again, it's not certain that this is a cause and effect. We're still learning. Does endometriosis morph into cancer? Probably not. But endometriosis can have associated with it cancers that either arise next to it, adjacent to it, or from it. It's still controversial. Again, the key thing we talked about, what can you do to take home today to decrease your risk? Birth control pill. That you can do.
Amazing.
Next. So all cancers are genetic, but that doesn't mean you can inherit it. So we live in a world where we're exposed to mutagens every day. Our body has mutations every day, all over the body, and most of us never develop cancer. But environmental exposure can cause you to develop cancer. So if you see on this slide, you have most cancers are still sporadic, which means it happens to exposure. Now, chances are those sporadic mutations are affecting the genes that we talked about, but you can't pass it on. So if you lived in Chernobyl, you would be exposed to radiation that could cause you to develop a cancer because of the radiation. It's not because you inherited something, you were exposed. Unfortunately, most of us are exposed every day to things that can cause us to develop cancer. And this is well known, whether you're talking cigarette exposure, coal, etc. So that's what the point of the slide is. Hereditary cancers are not as common as we think, but they all have a genetic basis. I'll get into the specifics in a second. So when somebody asks me, why did I develop cancer? I didn't have an answer years ago, but I do have an answer now. Everybody develops cancer because we don't repair DNA appropriately. DNA, our genes, are exposed to damage every day, and our body repairs it every day. So sort of like the New York streets. So when they don't repair it, you blow a tire, and when they do repair it, you don't blow a tire. So the issue here is we now know a lot more information about how DNA is repaired. And if DNA is repaired appropriately, you don't develop cancer. But if it's not repaired appropriately, these mutated cells divide, and cause us to develop a cancer. So DNA repair is critical in preventing us from developing cancer. Why am I showing you this? Because new drugs are being developed that affect DNA repair, that kills the cancer cells and takes advantage of their impaired repair pathways. And if we wanted to prevent cancer, we would identify people who had these repair pathway deficiencies, put them on medication to reverse it so that they did repair things properly, so their cells would never become malignant or cancerous.
Wow.
So this is going to be a tool for treatment today. It's being done today. And in the future, my hope is that this will be a pathway for prevention, so that anybody who has a known mutation can be treated such that it is prevented. That's my hope. Next.
Very hopeful. That makes me feel hopeful.
So tumor cells don't repair DNA very efficiently, but they can keep reproducing themselves. So we now have drugs that we're using today and for the past 5 years that attack the cancer cell's ability to reproduce. And by blocking that, we have a new paradigm in how to treat cancer, which is shown to be effective and increases survival. It's used in ovarian cancer. It's being applied to breast, lung, colon, and every cancer, bladder cancer, prostate cancer. So it's being across the board because there's certain common themes in all solid tumors in how they grow, divide, and kill us. And the key thing is DNA repair. So this is being taken advantage of today. So this is not a theoretical anymore. This is a practical. And there's at least 7 of these, they're called PARP inhibitors, that are in play in Europe. And right now, I believe we have 4 that are in play, soon to be 7 here in the United States, of drugs that impair a tumor cell's ability to reproduce by inhibiting their DNA repair. So, and again, if you want, go ahead, next slide. So let me deviate a little bit for a second. If you think of the Empire State Building being built, the first thing you have to do is clear the ground. So you have a crew that clears the ground. Then you have a crew that builds the foundation. Then you start building the structure. Then you have people welding everything together. Then you get the frame of the building. Then you get people to put in the electrical and the plumbing and this and that. So if you think about it, you constantly have bus loads of people coming to the site doing work. BRCA 1 and 2 are the buses. And inside those buses are hundreds of people that do different jobs. Those are the other genes that are involved. So there's over 300 hereditary cancer syndromes, and these are inheritable cancer syndromes. And these involve the buses and the passengers that are mutated that cause the cancer to occur. And we now know a bunch of these that are involved. So we can identify people at risk before they have cancer because we can identify mutations that set them up to develop cancer. Initially, we thought BRCA1 was named breast cancer 1, but breast cancer 1 is the bus. So it's involved in all the cancers in some respect. And then BRCA2, Ken Offit here in New York at Memorial found that, and that's bus 2. So again, the buses carry all these other genes and proteins that are involved in the process. So if a person has these genes and is healthy, they can be identified at increased risk, and then we can do something to put them into increased surveillance to try and identify, God forbid, if there's a problem, it can be found early. So what I'm showing here is about 25% of ovarian cancers occur due to inherited genes. And this number is fluid, so it can change. It can go down. Hereditary breast and ovarian cancer is another syndrome that has multiple genes here that are mutated that put people at risk. There's something called Lynch syndrome, which is a colon cancer, endometrial ovarian cancer syndrome, that has unique mutations that one can inherit to put them at risk before they develop. The Fermani, Cowden, Putz-Jaeger, these are other syndromes that are identifiable before somebody develops a disease so that one can be evaluated. So hopefully if it's found, it will be found early. So these are mutations unique to these individuals. Next.
Oops.
That's okay. So in the late 90s, early 90s rather, we had 2 genes. So it's very easy to do 2 genes. You either have it or you don't. The problem is in those 2 genes is over 3,200 mutations. So it's not just one mutation, there's 3,200 mutations. So unless you see the appropriate expertise, you're not going to get accurate information. It'd be like, you've flown on the plane a lot, Elizabeth. Do you want to sit and fly the plane? Right.
No.
So there is a board certified expertise, genetic counseling that is available. And anybody who is thought to be at increased risk, that's who a patient should see, male or female. Mm-hmm. Tell them your family history. They create a family tree, and they try and identify what you're at risk for and what tests, because the tests no longer are just for 2. Now they're for several hundred. And somebody has to interpret these results. So this is the only board certified expertise, a board certified MD geneticist or a board certified genetic counselor who is a graduate level trained person who has to pass written exams to be board certified. So their job is to identify people at risk and then to let that patient know, here are the physician that you should be going to because you're at risk for breast cancer, colon cancer, thyroid cancer, melanoma, brain cancer. So they act as a vehicle to send the patients to the appropriate healthcare experts so that their care is optimized. That's what a genetic counselor does. They're the only ones who have the expertise.
Would you recommend anyone who has a history of cancer in their family to see a genetic counselor?
Correct. And what they do is they investigate the individuals, they confirm the pathologic diagnosis, because a lot of people, my sister had stomach cancer. Well, actually she had ovarian cancer. big difference than gastric cancer. So again, creates the information, analyzes the information, confirms the information, and then coordinates the testing and appropriate referrals to those individuals. So yes.
Right.
The testing routinely is done on the person. So today we have a person diagnosed with ovarian cancer. That person is tested to see if she has a mutation. If she has a mutation, then her unaffected family members, siblings, as well as children would be appropriate to test. So we always try and test the affected individual first rather than unaffected family members. And I'll make it harder. Not only is the patient tested, but so is the tumor tested now. So it used to, you can leave that there.
Okay.
So in the past, it was just the patient. Now we test the patient as well as their tumor, because in theory, the patient could be negative, but the tumor could be positive. So that can affect treatment. Because we don't treat the patient, we treat the disease. And as we get more sophisticated, and I'll end with that, we have to individualize the treatment of the patient's tumor. So whatever the patient's tumor is should be treated, not necessarily the patient, if that makes sense.
That does make sense and very interesting.
So that's the basis of precision medicine. So here's an example of, all these genes can be evaluated. And the confusing part is there's multiple commercial labs and they all do different things and they all test different genes. So again, the genetic counselor can help determine which tests should be performed and then which lab is doing that testing. Because not everybody makes the same flavor of vanilla. And my example is you go to Haagen-Dazs, you go to Ben & Jerry's, you go to ShopRite. It's all vanilla, but they don't taste the same, do they?
No.
That's my point. Next slide. So it used to be simple. We test for BRCA1 and 2. There were 3,200 mutations just in those two genes. You get a report, very nice. Well, now, if you have several hundred genes, they all have these multi-gene panels. That's very, very confusing. So again, this is why a professional should be coordinating the testing. And my recommendation is always a genetic counselor. The weekend courses don't cut it for me. Okay, so what do we know and what is false? An annual CA125 and ultrasound do not achieve detection of early stage disease. CA125 was created by Bob Knapp and Bob Bass, brilliant physicians, and they made a commercial biomarker that we use today to determine if a patient's responding to chemotherapy who have ovarian cancer. It was never used as a diagnostic. It is not a diagnostic. The Academy of Medicine has said, do not use this. It's still done routinely. It's wrong. It does not help us diagnose ovarian cancer. We use this as a tool to see if a patient's responding to ovarian cancer therapy. CA125 test is a non-specific test. It is not a diagnostic test. So people ordering it are doing this inappropriately. And if your doctor is ordering this as a screening test, my suggestion is to ask them why they're doing this. Ultrasound, a snapshot in time once a year, can tell you right then and there you're okay. And I've been doing this since 1996, so I have no problem with the concept. And I think that since we know the clinical exam is so poor, in my opinion, I would have every woman have an ultrasound as part of their annual exam, because I don't believe the pelvic exam is accurate. And it's been documented, it's not. So the ultrasound, but just realize things can change in 6 months to a year. So if you have discomfort, don't sit and wait. Again, if it's longer than a week, go get evaluated. So CA125 is accurate in early stage disease. It's normal in almost half the cases. So you can flip a coin. It can give false security and inappropriate anxiety because there's many causes of elevation. Having a simple ovulation cyst, pregnancy, endometriosis, colon cancer, tuberculosis, many causes of elevation that have nothing to do with cancer. So it's not a diagnostic test. In an early stage disease where it's confined to the ovary, it's not even elevated half the time. So it's not a marker for detection. It's a marker for surveillance and responsive therapy.
So if your doctor recommends this, then you should say, can I please have an ultrasound instead?
Yeah, that's what I would say. If you're going to spend the money
I'm
for
gonna
the test,
say.
you might as well get tests that's helpful.
Yeah.
So again, it's increased to 80% of postmenopausal with ovarian cancer, yet about 45% of patients with stage 1 disease when it's curable. Many causes of false elevation, fibroids. So anyone with fibroids, it's going to be elevated. We know that. Benign ovarian cysts, just ovulation cysts, any inflammatory process in the pelvis, including Crohn's disease, irritable bowel, any enteritis, pregnancy, ovulation. So again, it's not a diagnostic tool. So ultrasound, in my opinion, and I believe this is real, is the best tool to visualize the ovaries over any imaging, MRI, CAT scan, PET scan. There's no tool that looks at the ovaries as well as the ultrasound. And the harmonics and the physics used to improve visualization, it's the best tool that we have. But transvaginal is the best imaging of the ovaries, not transabdominal, transvaginal. Mm-hmm. And it doesn't matter if a woman's 600 pounds or 80 pounds. The transvaginal approach allows visualization unlike any other imaging technology. And really what you want to know is, do they look normal?
Right.
It's not, this is not that difficult. Does it look normal? Yes. If something's concerning, then an MRI can have value or CAT scan can have value. But the initial test should be the ultrasound. And again, I've published this. It's been confirmed worldwide. There are tools that we can look at for abdominal blood flow. Blood flow can't be looked at on CAT scan or MRI. They don't have that technology. So there is and are developing tools to increase the accuracy. But right now, if you have a mass, yes, we can tell it's more likely cancer or not. But by that point, it's already, the horse is out of the barn.
Right.
So advanced disease is already too late. Next slide. So this is an example of a woman who didn't feel right. And she comes in and has, this 10 centimeter mass that looks like this right there in the office. And you see the red, that's the color flow. The color flows where it doesn't belong. And this is cancer. So right there, you knew she had a cancer just by using ultrasound. And she went to surgery and this was confirmed. So we've published this, we've documented this, it's known worldwide. Next. So Pap smears are not intended to detect ovarian cancer. So until it's proven that this is a new use of this technology because of molecular analysis, as of today, its only use is for cervix, and the goal is to pick up precancerous changes on the cervix so that a woman does not develop cancer of the cervix. Can it diagnose cervical cancer? Of course, but that's not the purpose. The purpose was to identify precancerous change. Next. So this is really a plug. Women at risk can prevent ovarian cancer as of today by removing the ovaries and the fallopian tubes. There are research studies going on now that are asking a question in women who desire fertility. If you take out the fallopian tube, can you decrease that woman's risk of developing ovarian cancer? And after fertility is completed, you would take out the ovaries. So say a woman is 35 and she's completed fertility, but she doesn't want her ovaries out. Taking out her fallopian tubes may decrease her risk for ovarian cancer in the future. This is a research study that's ongoing, and it will take about 20 years to determine if this is correct. So right now, the standard of care to decrease a woman's risk for developing ovarian cancer is to take out the ovary and the fallopian tubes. If you don't have ovaries and fallopian tubes, the chance of developing a cancer that looks like ovarian cancer is less than 1%, and that's called primary peritoneal cancer. The fallopian tubes may be the origin of some ovarian cancers because they look very similar. Ovarian cancer, fallopian tube cancer, and primary peritoneal cancer look very much the same under the microscope. So that's why they're all lumped together with the treatment and with the diagnosis. So if you said, David, I want you to prevent me from ever getting ovarian cancer, my answer is your ovaries and fallopian tubes need to be removed. And this is what we do routinely for women at increased risk. Don't take out the uterus. That's not a risk factor. It's the ovaries and fallopian tubes.
Okay.
So it's called a prophylactic bilateral salpingo-oophorectomy.
Wow.
I know,
Okay.
mouthful.
Yeah, but that's
Yes.
good to know.
So as we said earlier, the treatment, 90% of women who have early stage ovarian cancer, if it's confined to the ovary and it's a certain type, surgery may be all that's required, and the patient may not need any postoperative chemotherapy. Nothing done. So again, there's many types of ovarian cancer, and when you lump all of them together, your survival increases because you're taking the ones that are not dangerous with the ones that are dangerous. But the bottom line is very simple. Ovarian cancer contained at the ovary has a higher survival than when it's spread. It makes sense.
Absolutely.
If we had therapies that worked, then they all would have great survival. The problem is we don't have specific therapies to treat a person's cancer. That's why women lose their hair, they get bone marrow suppression, all the side effects. We want to kill the cancer, and we don't kill it 100%. And that's why people recur and recur and recur.
Mm.
Next slide. So I mentioned precision medicine earlier, and the whole point of precision medicine is where we're evolving in the world. Wouldn't it be nice to take your tumor, isolate your tumor, figure out what's wrong with your tumor, and then have a therapy that will cure your tumor? Historically, we lump everybody's cancers together and we check everybody the same chemotherapy, and we have no way of changing based on the tumor a person has. Well, precision medicine is, in reality, today, being utilized, but the problem we have is a lot of the drugs that we need to affect the pathways for each cancer don't exist. So a whole new army of drugs are going to be developed and brought into clinical care. So instead of saying you have ovarian cancer, we're going to say you have this pathway cancer. So it could originate in the breast, in the colon, doesn't matter. That pathway cancer is going to be treated with this regimen versus everybody with ovary. So individualized therapy is precision medicine, and that's evolving as we speak. And it is in effect today. So it is being utilized to optimize patient care. So it's no longer theory. We now know the genes, we know the pathways of the proteins, and now we're developing therapies that affect those pathways so an individual's cancer can be taken care of.
Very important.
Next slide. So our paradigm is going to happen like this. An asymptomatic patient is going to have their annual exam, besides your cholesterol check, blood that's going to be looking for proteins and genes that are involved in people at risk. And if they're found to be concerning, and we're talking here about ovary, then imaging would be performed, which would be an ovarian ultrasound, a modified ovarian ultrasound, where the ovaries would be evaluated. If there's a mass seen, patient goes to surgery. If nothing's seen, then nothing needs to be done. This way we can detect early stage disease. If patients have cancer, then we're going to use their specific tissue to tell us what therapies will work for them specifically. So those pathways of cancer will be prevented so that people will not die from that cancer. So the whole concept of early detection, prevention, and individualized therapy are coming, and they're evolving as we learn. COVID, we never heard of such a thing. The whole idea of the mRNA vaccine. So we've entered a new world of sophistication that is not going to be closed, and it's going to be applied to cancer.
Very promising.
Next. So again, take home birth control pill, absolutely. Breastfeeding, again, is a observational. Tubal ligation, again, decreases, but I'm not recommending people having tubal ligation to decrease risk because birth control pill is much more effective. And yes, you can have 8 or 9 children, but birth control pill is much more effective than multiparity. Next slide. Yeah. So again, I'm biased. We have a program here I'm very proud of, but we have international collaborators, national collaborators. So the take-home message is you can get great healthcare, but you have to be advocates and ask questions and push sometimes a little bit. You know, we're committed to patient care. This is what we're here for, but we utilize world-class science to offer that the best care possible. And we have a multidisciplinary program because cancer just doesn't affect the patient. It affects your spouse, their children, their family. And we don't treat people, and nobody should ever accept treatment as an organ. Okay, you're a whole person. And that means from toe to God. And that's the care you should demand and you should receive. And every place that's of merit should offer all those services to optimize a person's care, because this is not a solo journey. This is a horrible journey, and everybody needs help.
Really important message. And that's, the extraordinary thing about NewYork-Presbyterian is how much you're able to do for people and support people in so many different ways.
Well, it's an honor to work with good people. And there's teams of people who are committed to improving patient care, from the physical therapist to the speech pathologist to the nutritionist to the palliative care teams. I mean, it takes an army, and we have that, and any place that's of merit has that too.
And I can tell you too, it's like you're not only the doctors I've met from NewYork-Presbyterian, and you are certainly a shining star, is the care that you have for your patients. Not only do you have doctors that are the most experienced and most impressive backgrounds and they teach but really care about their patients, and that's extraordinary to me.
I'm proud of the group of people.
Yeah.
But again,
this was incredible. Please go ahead. I don't want to interrupt you.
No, I was just going to say, the issue is comprehensive care should be mandated and should be required. Patients should demand this. In any place that can't offer that, that's when you don't go there. That's all.
Absolutely. So this was so informative. I do have some questions I would love to get to. I do want to respect your time, but let me try to get to as many as possible. Claudia wanted to know, what if your cycles are 20 plus days, less than 25? Does that make you more susceptible to ovarian cancer?
No, because there's no, the short answer is no.
Okay.
I don't want you being worried.
Good. Diana wanted to know, do you still recommend birth control if in menopause stages?
Well, there's no need for birth control pill in the menopause, because the whole purpose of the birth control pill is supposedly ovarian suppression. So suppression of ovulation, that's the theory. And it's thought of and controversial and uncertain, the mechanism. And it's probably a lot more sophisticated. It's probably the progestin. So the answer for menopausal people is no.
What about if you're older? What about if you're not menopausal, but you're older? You're not. Do you recommend at any age taking birth control for 5 years if you haven't in your earlier years?
Yeah, it's 5 years lifetime use. So it can be any time before the menopause that has shown the effect. Remember, the average age of diagnosis of ovarian cancer in this country is approximately 52. So anytime premenopausal, in theory, and from the evidence from the literature, suggests that it decreases one's risk. So you don't have to be 5 years continuous, but sure. I mean, my philosophy has always been, if you're not trying to get pregnant and you can save your life, why not take a medicine that can help you?
Absolutely, 100%. I agree. Claudia wanted to know, excuse me, is birth control okay for high-risk breast cancer patients? And should you follow up with gynecological oncologist if you have a follicle in your ovary?
Yeah,
Different questions.
yeah, no, it's a great question. So it's complicated to give generalizations. So a high-risk breast cancer patient who doesn't desire, who's not on tamoxifen or medication to decrease their risk, you have to have this discussion with your medical oncologist who's has you on suppression. So if your risk is 60% to develop breast cancer, the birth control pill is being used for a different reason. It's to decrease your risk of ovarian cancer. So you have to put all these different medications in discussion with your healthcare provider. Some will say it's fine, some will say no. So it all depends on somebody's personal situation. Somebody has an early breast cancer, again, can be on birth control pill, but again, medical oncologists have different opinions. So unfortunately, I can't give you a specific answer because there's a lot more information that is needed I need more information.
But the question is a good one for her to pose now with her doctor.
Oh, absolutely. Absolutely.
So even that she's thinking about it is a good thing.
There's never, ever, ever a reason not to pose these questions to your healthcare provider, because the truth is, it's you. And you should never be afraid to ask a question of your healthcare provider, no matter how off the wall it is. That's why they're there. We're here to help you. So bombs away.
Absolutely. And hopefully we've given you some good information to go ahead and ask about. Dee is interested about menopausal women and ovarian cancer in general, and then also specifically if, as having had a tubal ligation in her past and how that affects her future for ovarian cancer.
So a tubal ligation may decrease a woman's risk 3-4%, not 50% like a birth control pill. And the reason for tubal ligation is not to decrease one's risk of ovarian cancer. That's just, oh, by the way. And more likely that's because of premature ovarian failure. When you take thousands of women, that may be. So it's not necessarily, it's not the standard thing we would say to prevent ovarian cancer. It's, oh, by the way, their incidence was decreased. The big thing as a postmenopausal woman is making sure that your examinations are thorough. And if you have discomfort, make sure that you bring this to your doctor. And in the process of any evaluation, you have your ovaries evaluated. I mean, Steve Goldstein, who is a colleague here in New York, has been advocating every woman to have a ultrasound every year as part of their annual exam. And I honestly agree with him, because if your accuracy of the pelvic exam is 25%, to me, that's a worthless test. That would be like going to your cardiologist and asking him to listen to your heart outside the door. It doesn't.
Now, does insurance cover this since it's not a routine thing? I'm not an insurance expert, but generally.
No, the insurance companies are very smart. They don't want to pay for anything because, they're for profit. So if you don't spend money, you make money. Medicine's not cost effective. It surely isn't. And I'm sure, listen, our society doesn't want to pay for mammograms or Pap smears. So if they don't want to, but to me, you save money by prevention. So I don't know. I would do the ultrasound if I was a female.
Okay. And it's a very important conversation to have with your doctor and bring it to the forefront. Wilma says, I'm on estradiol. Am I saying that right?
Yep.
And just got a period after menopause for 2 years. Is this normal? And can estrogen cause cancer?
So no, that's fair. So estrogen can cause cancer. And if she has a uterus, she should be on estrogen and progesterone. And if she's on estrogen alone, she should ask her doctor why. Because estrogen can stimulate the lining of the uterus and you can have a period. And unopposed estrogen can increase a woman's risk for endometrial cancer. So I would be asking my doctor, why am I not on both?
Great question.
We have to make sure she's not my patient.
Well, you'll know because she's going to ask you this question. Dee wants to know, who does one go to see if there are genes or genetic mutations? We talked about this. And do you recommend that everyone get this testing done, especially if they don't know their family history?
Testing is, pretty soon you're going to be able to do mail-in genetic testing. Why not? Our country is, freewheeling. The truth is, you should talk to your healthcare provider and ask your doctor what their thoughts are. As I said earlier, the only people who are truly experts to know what tests should be ordered, because you need to know what test, it's not just one test fits all, is a genetic counselor. And I mean, you can Google genetic counselors, and there's many in across the country. In fact, there's some that will do telegenetic counseling over the phone, and some may charge a fee of $100, and some may be covered by your insurance. I would start with a healthcare provider, but if you have a question, genetic counselor is the way to go.
Great. Diana wanted to know, how often should you check for ovarian cancer?
Well, in theory, that's part of your annual exam by your gynecologist, and they should be doing a pelvic and rectovaginal exam. Now, I know this may be painful to everybody, but that's the standard of care, is a bimanual rectovaginal exam annually. So lots of doctors don't like to do that because it's uncomfortable. Men don't like it either, but we get one every year too, so we share your pain. The issue is, when we see women at high risk, we see them twice a year, and they get exams and ultrasounds. The standard now for women at high risk for breast cancer is MRIs and ultrasounds. So they're being seen twice a year. So increased risk people are being seen twice a year. Colon, it depends on what was seen, but it's less than every 5 years. So there's lots of different diseases have different regimens. Lung has different than prostate, that has different than pancreas, and they're evolving. So what was is changing. So most of us do every, twice a year for any of the high risk, breast or ovarian people.
Okay. Terry wanted to know, can the Bracha gene develop over time, or are you born with it?
So we all have a Bracha gene, but the mutations we can inherit or they can mutate. As we said earlier, some of these genes are inheritable, meaning you inherit the mutation, and some you yourself don't have that mutation, but your tumor does. So that's why we're doing testing of the person as well as the tumor. The tumor testing is new. So the answer is, we all have that gene, but we don't have that mutation.
Okay, that's it. I didn't know that. That's very interesting. Claudia wanted to know, are all ultrasounds made equally, or is there a machine that's better than another?
It's like Helen Keller looking at artwork. It's not the machine that's the problem. It's the person who's reading the results. So yes, there are many different types of machines. The ones that hook up to your iPhone can't possibly give you the resolution of one that costs $500,000. And this is where cost does make a difference. The harmonics, the probes, the sophistication. When the probe costs $15,000,
wow,
that's just the probe.
Unbelievable.
And the crystals in the probe, these are very delicate, very sophisticated tools that shoot sound waves and interpret. So the machines make a difference, and who's reading it makes a huge difference. So it's not even close to being equal.
So I just shared New York Presbyterian Queens information. This is why you go to a place like New York Presbyterian Queens, where they have the best doctors, the best facilities, the best equipment. So I shared here the New York Presbyterian website for cancer, as well as a phone number I shared here, which is 718-670-1731. I'm also going to send an email tomorrow that will include that information as well. Before we leave, because I do want to respect everyone's time, we could spend here all day asking you questions. Dr. Fishman, you're so generous. But Wilma has a question that's very important. Are you accepting new patients?
So I actually, my group, we do all the ultrasounds, and we've had NIH funding for our ultrasound work. We published our work. So we can see anybody for gynecologic ultrasound. We do not do OB ultrasound. I am not an OB doctor. So yes, we see patients Monday through Friday in our Forest Hills office, and we do all the ultrasounds. So we have superb technicians, and again, we have a team that I'm very proud of.
Fantastic. So there's your answer, everybody. Click on the link, call the phone number, and get yourself in to see a doctor, Dr. Fishman, his team, and the people over at New York-Presbyterian Queens. Thank you so much for this time. I know you're such a busy doctor, and I really appreciate you taking the time to educate us. I know I learned a ton. I'm seeing so many thank yous in the chat. This has been so valuable, and we really appreciate your being here.
Well, Elizabeth, I appreciate the opportunity. And again, our commitment here is to help everybody improve the care they receive. So again, we're here to help. That's what we're here for.
A million thank yous. And to all of our attendees, thank you for joining us and spending some of your afternoon with us. Again, as I shared, this is being recorded. We will have it up on YouTube, Schneps Media website, to be able to receive. You'll have a link in your email tomorrow about that. So you can watch it again, you can share it. Please share it with your community. We want to get this information to as many people as possible. So thank you all for joining. I wish you all to stay safe, stay healthy, and we'll look forward to seeing you on a future webinar. Bye, everyone.
Thank you.